Welcome back to part 3. This is the prosthetic stage. Now, during the 3 months that we had for the implants to heal, we didn't waste that time. The patient had very specific aesthetic requirements, and I needed to ensure that the photograph that the patient had in his mind of what his final work was going to look like was the identical photograph that I had in my mind. So we had a number of steps that we performed along the way to ensure that these two photographs were the same, because if these two photographs are the same, you get the best possible outcome. So we went through a few stages. The first is that we did a mock-up and we did a intraoral wax-up, and I will show you what that looks like. The mock-up was teeth that looked more similar in terms of color and shape to what the patient desired, and these were placed on a clear orthodontic retainer so that the patient could place these in his mouth and take them home and assess whether his aesthetics and his function and his speech were optimal with these in position. The patient reported that he was happy. He wanted a few small changes made, and then we proceeded with a wax-up. So we got my technician to make a wax-up for me with a horseshoe-shaped wax palatal surface with 2 little clasps and with an almost identical shape, size and color to what the final teeth were going to look like. Patient then agreed to this. He was happy with this as the final outlook, and this gave us a clear and measurable target to manufacture against. We discussed him going to his dentist and having a little bit of tooth whitening on the adjacent teeth, so that it gave him a much better blend in terms of final aesthetics. I did assure the patient that the final crowns would not be monochromic like these, but would be more translucent and more natural looking. But this is an important step, because if you then place the patient at the end with crowns in terms of size and shape and color that he doesn't desire, it's back to the drawing room. This prevents a lot of problems in the long term. So John came back to the clinic for a checkup. His oral tissues over the implant sites looked pink and healthy, and his hygiene was excellent, and that always makes life a lot easier. Now, John did have a few financial constraints, so he decided to delay the final crowns for a while. But he was very clear. He wanted individual crowns, not splintered together. We discussed the pros and cons, and by the end of the day, it was his smile and his choice, and we respected that. And the data does support that individual crowns have the same longevity and lifespan as splintered crowns, especially in solid bone like this. So fast forward a month later, I placed John in a semi-supine position. I removed his provisional partial denture and inspected the soft tissues, and all were looking healthy. I gave him some local anesthetic buccal and palatal and made a small incision on the palatal aspect and left lots of this buccal gingiva and exposed the 2 underlying implants, and you can see the cover screws. We performed an Ostel ISQ test on these implants. The Ostel ISQ values on the 1-1 were 75 in this direction, which I call the A direction, and 69 in this direction, which I call the X direction. And in the 2-1 site, the ISQ values were 69 along the A and 73 along the X. These readings confirmed that the implants were stable and healing well, and at this point we began bone training, a gentle way to prepare the implants for final loading. So bone training is a concept that was taught to me by Professor Paul Weigel in Germany, and it is a predictable and safe way to take implants that haven't fully stabilized and to use progressive bone loading to stabilize these implants. It is a measurable and predictable method of stabilizing implants and getting the optimal outcome We will discuss this a bit further in subsequent cases. We then took impressions using an open tray silicone impression tray. We recorded the bite and we obviously took photographs. Shade selection was done using a Vita Tooth Guide 3D Master, and we went for a shade 3M2, slightly more translucent incisally to mimic the natural teeth. This is a periapical of the two impression copings in position. It is paramount to always do this to make sure that they are correctly seated and there aren't any gaps. Any micro gap in this area will cause consequences on final aesthetic cases. This is of paramount importance. Here is the photograph of the silicone impression tray with the two impression copings in position. Healing caps were placed onto the two implants and were placed just a little proud of the gingiva and sutured in position. Now, this is where the bone training comes into place. So when the partial denture is worn by the patient, we would trim the fitting surface of the partial denture very carefully to just gently press on these two healing caps. That pressure then puts pressure down the implants, and that stimulates the bone to osseointegrate even further, and it stabilizes these two implants. I want to be very clear that the pressure onto these two healing caps must be gentle through the partial denture. The patient was sent home with post-op instructions, and we scheduled a visit for a month later. A few small changes were made to the wax-up and to the mock-up as per the patient's requirements until we had exactly the correct length, width, shape, size of the final teeth that the patient desired. And we prepared then for final stages. On the return visit, the first thing that I did was to check the position of the implants on the working model by removing the gingiva, the silicone gingiva that the lab placed for me, and then to inspect the implants very carefully. I rechecked the ISQ readings on the 1-1 and got readings of 75 and 75, and on the 2-1, 73 and 73. These were perfect results, and I was delighted to see that. I purposely removed the little silicone gingiva to ensure that the emergence profile and the fit around the implants and the crowns is to what I desired. I checked that I could place dental floss around these areas. However, made it very clear to the patient that around implants they are not to use dental floss. They can and must only ever use interdental brushes. No floss around implants, only interdental brushes or water picks. Carefully inspected the final crowns on the models, and the patient was delighted with the final crowns on the study model. This is the left side view to show you the proclination of the implant crowns, and this is the right side view of the implant crowns on the working models. Radiographs taken confirm proper seating of the crowns and the abutments onto the implants. This is prior to torquing the final implant abutment screws. We tried the implant crowns in the patient's mouth. This is the palatal view. It is common to see blanching around the implant crowns when fresh crowns are placed around standard produced healing caps. Because the patient was a thick biotype and I wanted to create beautiful gingival margins, we decided to expose not just the healing caps, but to give me a little bit more movement to then seat the crowns correctly and then to adjust the gingiva around the implant crowns. We tried the implant crowns in the patient's mouth, and we can see the slight bit of blanching as we previously described. This is the left side view. This is the frontal view of the implant crowns in position, and we can see the blanching in this area. Patients are informed that this disappears within 15-20 minutes. And this was the right side view of the implant crowns at the time of fitting. The implant crowns were torqued in position using an appropriate torque wrench to the optimal torque. In this case, it was 25 newtons per centimeter. It is very important that when you torque that you follow these correct prescribed procedures where you place a little bit of pressure to hold the driver directly vertical in position, and that you drive only using the torque wrench and not engaging anything else. As you all know, I prefer to use gold screws. That's what I did my master's thesis on. And I covered these gold screws with Teflon and with composite. We polished everything and double checked the interproximal areas, no bonding remnants to irritate the gums. So just before John left, we did one final check. We gave him very careful instruction in terms of oral hygiene, that he was not to use dental floss but only interdental brushes. And we made a follow-up visit after a week and then asked him to return to our surgery 3 months post-op for a proper long evaluation. So what are the key takeaways of this case? The first is that mock-ups and wax-ups are a clinician's best friend in terms of closing the gap between what the patient desires and wants and what the clinician is able to deliver. 2. ISQ readings are paramount in terms of being able to assess implant stability. It is a very powerful tool that clinicians should always use in implant cases. In combination with progressive bone loading, or what is called bone training, this is a very powerful tool to be able to give you the best possible clinical outcomes. 3. Attention to detail in terms of proximal, distal contact points and positioning of the crowns is paramount to get the best possible aesthetic outcomes. 4. Patient oral hygiene and education is paramount so that the patient knows how to maintain, protect, and get the best out of their investment, because ultimately this is a massive investment for the patient. And finally, communication is paramount. There has to be lots of communication between the patient and the dentist, and make sure in your treatment planning that you put aside enough time to be able to have those necessary conversations. There you have it. That's the complete start to finish of how to deal with a case like this. And we will see you for part 4, where we will do the 3-month post-op checkup.